हम दवे सर का शुरू होने वाला है।
सर बोले why this video is not coming? आप कर लो. She knows how to do it.
Please wait with us. We are just going to start playing it in a while.
Abra, do you have CV of Dr. Dave?
No, sir. We unfortunately do not.
Hello?
Hello? Hello? Hello?
आया है? आज 10 मिनट आएगा नहीं आएगा?
लेके
तो रिकॉर्डेड भेजा है ना?
Hello? So we unfortunately do not have his CV with us.
You have CV, Dr.
No,
Dave?
sir. We unfortunately do not have his CV with us because this was unexpected.
Raju has got. He's just bringing it. Okay.
Okay, sir. Okay,
Just
sir.
opening.
Yes, sir.
A minute. आप बैठिए ना इधर.
नहीं ओपन करेगा नहीं करेगा.
सर स्क्रीन पे आ रहा है. सीवी स्क्रीन पे आ रहा है.
किधर?
आप ये लगाओ ना. सर पासवर्ड बोल दो. आपका पासवर्ड आपका.
So shall I introduce?
हाँ. Yeah.
पासवर्ड.
I can't read this.
We have the privilege.
इलाज करो ना इसको.
So may I start now?
Yeah.
Thank you, sir.
Yeah, you go ahead, sir. Go ahead. Go ahead, sir.
Good morning. I am Brigadier M.S. Raj. This is to, firstly, I wish to welcome Professor Subed Dave, Farsi Sai, Dean of the Royal College of Psychiatry, London. Professor Dave is a dear friend, and firstly, I must express my gratitude to him for accepting the invitation at an extremely short notice. We know he keeps a busy schedule, but yet he could spare time for us. It is really, I am really grateful. Professor Dave, just to introduce Professor Dave, he is a consultant psychiatrist and deputy director of undergraduate medical education, Derbyshire Healthcare Foundation Trust. He is the dean-elect, successfully contested the election this year. Royal College of Psychiatrist, Professor of Psychiatry, University of Malta, and he is the chair of the Association of University Teachers of Psychiatry, vice chair of Bapio Institute of Health Research. He is always keen on enhancing community engagement to enable the delivery of person-centered care. Now, this is a standing conversation between me and him. He is a very extremely keen athlete and marathon and mountain climber. I was thinking I was just cracking a joke on the other day whether he'll make his students do the marathons before they get graduation. Now, he has many glittering achievements to his credit. Because of shortage of time, I'm not going into detail. We all know Professor Dave. So, once again, I express my deep sense of gratitude to Professor Dave uh, for being with us today here. Thank you, Professor Dave, and may I request now to deliver your lecture, please.
Thank you, Raju Garu, for organizing the conference, and thank you for inviting me here from the UK. So I'm delighted to be here. I wanted to share my experience of training in the UK, and I know that whenever I visit India, a lot of people ask me about how they can get clinical experience. Of working in the UK. So I'm going to share some of my thoughts with you all today. So, and this is where I work now, which is in Derbyshire and Derby in the UK. And this is the university now I'm attached to. And so you can see the similarity in the structures between Nottingham and Mumbai University. I've also led the postgraduate training program in Zambia in Africa, and that's the building in Lusaka, the University Teaching Hospital there. So I'm privileged to be associated with so many wonderful places. I'm really privileged to be working for the National Health Service, which is one of the world's largest employers. As you can see, that it's the 5th largest employer in the world, and it employs over almost 200,000 doctors. So really proud to be a part of that organization. We have a very large number of therapeutic clinical staff as well, technical staff, and a large percentage of the employees are professionally qualified clinical staff. I wanted to share this slide of work of the healthcare system performance rankings that the Commonwealth Fund publishes every few years. This data is from 2017, and you can see that the United Kingdom gets an overall ranking of being the best healthcare system in the world. And this ranks on a range of parameters. As you can see, it talks about care process and access of care. And so care process is one thing where UK is a winner. And I think we really have a very good pathway system, a very strong primary care system, a good, strong secondary and tertiary care system, and excellent pathways that negotiate the care system. And the equity of access is very important. So whether you are a billionaire or whether you are very, very poor, everybody gets the same access to care. And whether it's a million pound liver transplant, or whether it's cough and cold medicine, it's all available free at the point of delivery with a minimum prescription charge, and that is available to every citizen in the country and every resident in the country, in fact. So which is a unique thing amongst many nations. And this is the building, the Royal College of Psychiatrists. So some of you may have visited us there. So very proud of this building. This is the headquarters of the Royal College of Psychiatrists in London. And I will soon be, working there as the dean from this summer. and really privileged to have been elected as the Dean of the Royal College of Psychiatrists. And as a part of this role, I will be in charge of the education portfolio and training portfolio of all the psychiatrists. So really excited to be playing that role. So just a brief snapshot of the kind of services that we have in the UK. As you can see that we have a whole range of community-based services. So there are community mental health teams, early intervention teams for psychosis, crisis resolution and home treatment teams, we've got day hospitals, crisis houses. These are like regular houses in the community where people who are in a psychiatric or a social crisis can go in and have a change in their social milieu. We have a range of specialist services like the forensic mental health service, the perinatal service. I work in a liaison team, and it's very, very, stimulating, and I really enjoy that. And we obviously have children's services, psychotherapy services, a whole range of services. And we have what are known as mental health trusts. Now, this is mainly England. In Wales and Northern Ireland and Scotland, we have health boards. But it's essentially the kind of experience that someone who's coming to the UK is likely to get is on the pathways to good quality care, on how is patient experience monitored and delivered, and how are patient services delivered in a safe and effective fashion. And so all of this is underpinned by processes for evidence-based healthcare, quality improvement, learning from medical errors, involving patients in care planning. And there's a whole governance mechanism. So the administering of care, because ultimately I think this is a lesson that I learned from my early days at Grant Medical College in India, that we often try and deliver our best quality care, but we don't always think about how can our science translate into good patient outcomes. So just to give you a small example, I used to have, run outpatient clinics 3 times a week in Grant Medical College, and they were very basic clinics, and we used to have 6 or 7 new patients in the morning, anything between 50 to 100 follow-up patients. And people would come milling around, and I'm sure this is true even now, 6, 7, 8 in the morning. And sometimes they would not be seen till 1 o'clock. And not once did I think that we should set up a register for our patients so that people can register the name, go out, have a cup of coffee or something, and come back. And I feel that thought process of not wanting to deliver the best care experience for our patients is something that we need to inculcate in our educational system. And I feel that's something that we try and do and endeavor to do in the UK, and certainly something that we can share, learn from. But research is a big part of our working life in the UK. So we have a National Institute of Health Research that is specifically designed for research to be conducted at the clinical front line. So all the trusts are involved in clinical research, mostly through recruitment in large clinical trials or large clinical projects. And over 600,000 patients have participated in the research. And one of the big gifts, I think I would say, to the research world that the UK has provided is getting patients involved, not in just as trial subjects, but actually in designing research so that that research actually translates into good outcomes for patients. And we've played a small role in Derbyshire. I think we run one of the largest programs of patient involvement in medical education, in psychiatric education. And we conduct research around patient involvement in psychiatric education. And so quite proud of that program. And, hopefully some of you will be interested in that, and we'll get in touch to know more about that. But as you can see, that it's a massive program with more than £3.5 billion of additional funding and support for research in every trust. And anyone who comes and works in a trust has the opportunity of getting involved in research. So this is a body that works only in England. So some of you may already know the United Kingdom is made up of 4 nations: England, Scotland, Wales, and Northern Ireland. So England, Scotland, and Wales make up Great Britain, and so United Kingdom is also referred to as Great Britain and Northern Ireland. So Health Education England exists in the most populous nation, which is England, and it is responsible for the delivery of excellent healthcare and health improvement patients and the public of England. So it is really involved in the training of the workforce, and again, it's got a large budget of about £5 billion, and that pays for the salary of trainees, not just in medicine, but also in nurses, OTs, physiotherapies, and all of their training. So coming to gaining experience in the UK and how can you gain experience in the UK, I'm going to move that a little bit, yeah. And so one of the easiest ways is to come and get some clinical experience in the UK. If you don't have a work visa, or if you're not registered to work in the UK, that is, you require GMC registration, General Medical Council registration, is to do a clinical attachment. And if you might, if you Google this, Clinical Attachment, a Guide for Doctors, that I've authored, it's a Royal College of Psychiatrists publication, that gives you a good idea of how to go about the process and how it will help you. But essentially, the advantages of clinical attachment are that you don't need to do the PLAB exam, or don't need to go through the GMC registration. And so expense-wise, it's a relatively easier process, but you can only observe. You can't actually work, and obviously you don't get paid. There are some specific programs. So in the east of England, they run a specific attachment program, but you can contact pretty much any NHS trust and request them. And it is good if you want to gain experience in a particular area of psychiatry. So if you want to come and observe neuropsychiatry, eating disorders, child psychiatry, etc., that's a good way of doing that. And the Commonwealth Fund also runs a scholarship program, and we've had people apply through the scholarship program and come and work with us. So that's also an opportunity. Now, if you want to work in the UK as a doctor, then I think you require General Medical Council registration, and you require an appropriate visa. Now, with visas, I would say that go to the UK Border Agency website and look it up, because that keeps changing. I think very recently they come up with a new visa, a health worker visa, and which has quick turnaround times. You can get the visa very quickly, and it exempts you from certain expenses. So it's worth having a look at the latest information that the UK Border Agency offers. Now, normally, when you apply for this visa, you need to satisfy a resident labour market test, which essentially means that the employer in the UK should have tried to employ somebody from within the UK first, and only if they have failed to employ that person from within the UK, then they can go out and employ from outside the UK, from abroad. And that list is regularly revised, but usually I think some psychiatrists for certain professions, general adult psychiatry or old age psychiatry, are on that list when I last checked. But again, please check the list, because you may not be hearing this live. So what are the ways to get GMC registration? You can pass the MRC Psych exam, and as you all know, you can, or probably know, you can do the MR Psych exam while you are in India, including the CASC exam, which can be done outside the UK as well, from Hong Kong or Singapore. And of course, in last year, in the COVID period, we've had the CASC exam being done online. And so people have been able to appear on that exam on the digital platform, even while they were in India. But those who have not done postgraduate psychiatric training outside the UK may not be eligible to appear for MRC Psych, but then they can do the PLAB exam, which is a Professional Linguistic Assessment Board test. Again, all the information for this is available on the GMC website. Another route to get the GMC registration is through the Medical Training Initiative, and the Royal College of Psychiatrists, we run this MTI training program. It's been running once a year. The applications are open. In the next round, we'll be conducting interviews fairly soon in April. So again, look it up on the college website. If you Google MTI and Royal College of Psychiatrists, this should come up. You should get all the information that you need. And there's also an email address to contact if you have any queries or questions. Now, there are other sponsors that run somewhat similar programs to the MTI, and they are called different things. Some of them call it International Fellowship. Some of them are tied to an MED master's level program. And so you can come through that route as well. So again, check the and weigh up as to which is the best option for you. And if in doubt, I think always contact senior people who have been in the UK, have experience. And I think there's the international division of the college, and the officers are, I think, current officers are from India, actually, as it were. And so you certainly should be getting in touch with them. And again, if you look up the college website, you should be able to get access to them, or should be able to send them an email. And some of them are on Twitter as well, so you can contact them directly on Twitter. And the last thing is the certificate of eligibility for specialist registration. Now, this is possible for a small number of cases where people haven't gone through the usual training route in the UK, but if they can demonstrate that they've acquired the same competencies in the non-training route, then they can get what is known as the equivalent qualification to what is the known as a certification of completion of competency, CCT, and that competency completion of training, which is awarded for specialists. So I have a CCT in general adult psychiatry with an endorsement in liaison psychiatry. Occasionally, if you fulfill these requirements, it's possible to get it through the CSER route. And I think it's becoming more and more popular. So that's something, again, worth considering. Now, working in the UK, like I said, so you do need PLAB registration or registration with the GMC, and you need evidence of completion of foundation training. So you need to demonstrate that you have at least 12 months experience after full GMC registration or equivalent, and evidence of achievement of those foundational competencies in the 3 years preceding the start of your employment. So one of the things you need to demonstrate is English language competence, and the academic competence is demonstrated by IELTS. Most of you will be familiar with the IELTS exam, where you're required to score an overall score of at least 7.5, or an occupational English language test. But again, check your employer's requirements for the latest levels. The foundation competencies, there's a whole range of competencies, as you can see. And I would advise anyone applying to come and work in the UK to actually look at these seriously, because if you have any assessments, whether it's for the MTI scheme or PLAB or anywhere else, you will be judged against these standards. So the very first one, which is, I think, very important, make the care of the patient your first concern, will be something that will be assessed. And either through an OSCE scenario or through an interview, whatever process of assessment you're having, I think employers will be interested in knowing if you are actually making the care of your patient your first concern. Do you always prioritize your patient care? And whether, obviously, you're a competent practitioner, that you're able to provide a good standard of care, you treat patients effectively and safely and with dignity, and that you're able to work as a team member with patients and other team members, and that you are able to work in a professional fashion, with honesty and integrity, and do not engage in any unprofessional behavior. So I feel that I think I've already outlined a case as to why National Health Service is one of the best healthcare systems in the world, and I think it's a great experience to come and work in the NHS, and it can be a very rewarding experience, even if you're planning to go back. We get a lot of trainees coming from Sri Lanka, for example, to train in the UK, and then they go back and then they find that they are able to utilize that knowledge and skill and professionalism that they've gained in the UK to improve the healthcare services in Sri Lanka. So I certainly feel that it's something worth recommending. Now, if you're planning to come or appear for any of the assessments, I think there are a host of resources available. But some of the clinical scenario kind of resources are available at the University of Nottingham training videos, which are available on YouTube if you Google them. Clearly, ICD 10 criteria is something that is available everywhere. You all must be familiar with them already. But the leaflets that the Royal College of Psychiatrists produces are fantastic, and I really recommend them as a great resource. So do have a look at them. And then there are the NHS.UK, which is a fantastic resource for almost a whole range of every medical condition that you can think of, including all the psychiatric disorders. And there's also a website called patient.co.uk that is oriented towards patients, and I think it will provide you with information in a non-jargon fashion, which I think would be useful if you're planning to do any exams or assessments or interviews. So my key points, take-home points for you would be that be person-centered. Always think about your patients first, and think about how will you try and make a difference to their outcomes. And if you are planning to appear for interviews, I think make sure that you've got real examples of audits or quality improvement projects that you have done. Or if you haven't done them, I think of real examples that you have been involved in your working life, where you tried to make a difference to the patient or your patient's relative. And I'm sure you all have those examples, but if they are real examples, you'll be able to talk about it as to how have you actually tried to make a difference to your patient's outcomes. And make sure that this person-centeredness is demonstrable at the interview. A lot of the times we see people and they give very bookish answers. So, rather than thinking about how would they actually treat the person in front of them, they give you, so if you're asked about how will you manage delirium, if you give a bookish answer, it's very different to actually thinking about how will you deal with the person who's suffering from delirium, right? And so avoid jargon and then focus on patient safety clearly. So I'm going to end there. Thank you again very much, and I wish you all the success for the conference. I know it's at a time which is very early in the morning for us in the UK, so my apologies for not joining you live, but it has been a pleasure to send this recording to you, and I wish you all the very best.
Thank you, Professor Dave, for an excellent overview of national healthcare services, the philosophy of the medical care, healthcare in UK, and also wonderful tips for international medical graduates to get work experience at various levels. Thank you. Thank you so much.
Hello.
Good afternoon, sir.
Good afternoon. Am I in the correct room?
Yes, sir, you are. You are.
Yeah. Can you see me?
Yes, sir. You're visible, sir. So
It's
we'll
visible.
just, there's a small lag, sir. We will just fix that.
Yeah.
Good afternoon, everyone. We are in the middle of the second session for today, and we have the privilege of having respected Dr. Ivan Neto and Dr. Colonel K. Sebi as chairpersons for this session. Dr. Ivan Neto, he is currently a consultant psychiatrist at Parmar Plaza Clinic, Pune, and an associate professor at BJ Government Medical College and MIMH. He is the chairperson of the Forensic Psychiatry and Law Specialty at Indian Psychiatric Society and the field editor at Indian Journal of Psychiatry. He has teaching experience in undergraduate and postgraduate courses, and he has been an examiner at MUHS since over 20 years. He has done COVID-19 research, a qualitative study regarding stress and coping of frontline postgraduate trainee doctors working at a COVID hospital. He has also done COVID-19 based research on a study of the impact of COVID-19 on patients with severe mental disorders and their caregivers. At Yarwada Central Prison from 1985 to 1990 and Sassoon Hospital from 1990 to 1997 and 2007 to 2015, he has been involved with forensic psychiatry. He has many publications and citations under his name, and he has achievements of training at COVID-19 healthcare workers, participated in the Delphi study for the validation of the ICF course sets for schizophrenia, and he has trained at the alcohol and drug addiction centers and conducted workshops in psychiatry.
Good afternoon.
Our next chairperson for today is Colonel Dr. K. Sabi, who is a senior advisor and head of Department of Psychiatry in Indian Naval Hospital, Ashwini Kolaba. He has done his MBBS from Armed Forces Medical College, Pune, and his MD in Psychiatry at Medical College, Pune in 2004, where he also stood first in the University of Pune. He has done his PhD in neuropsychiatry from NIMHANS, Bengaluru. He has 11 publications in this field, and his area of interest lies in neuropsychiatry. Welcome, sir. We are very privileged to have you with us. May I
Thank you.
hand over the proceedings to the chairpersons now?
So Dr. Sabi, I'll begin, and then
Please,
you
sir.
can also intervene whenever.
Sir.
So it's nice here to chair this session of international speakers, and especially speakers who have gone abroad who were previously in India. The first speaker, as we can see here, the list is put up. I think if there could be some just mute the speaker because there's a lot of disturbance. Yeah, so welcome to this very interesting and enriching discussion from international speakers who were previously in India. The first is Dr. Nikhil Kisti. Dr. Sabi, would you like to introduce him?
Yes, sir.
Yes.
Good morning to all of you. Good afternoon, rather. We welcome Dr. Nikhil Kisti, who was my senior from FMC while doing MD Psychiatry. If ever there was a brilliant psychiatrist, he was the one. His notes of psychiatry are legendary. And to no one's surprise, he stood first in the university with a distinction in MD Psychiatry exam, which is unheard of for a psychiatry resident. So he has been a brilliant psychiatrist, and he has been a role model for all of us in academic psychiatry. Unfortunately for us, he went to India and went into greener pastures. He went to UK, did his training in forensic psychiatry, and now he's a consultant in forensic psychiatry. He is now a medical director there. His detailed CV is on display. As we know, forensic psychiatry is a nascent branch in India. So we hope at some point of time later, that Dr. Nikhil Kisti would come back to India and maybe help us start some training program in forensic psychiatry. So we warmly welcome Dr. Nikhil Kisti.
Thank you very much. First of all, thank you for inviting me to the conference. It's such a pleasure to actually see the names of many of my colleagues and seniors. And I think in a way, the pandemic has been beneficial because otherwise it might have been very difficult for me to actually join or contribute. Thank you very much to Dr. Chaudhary, who has been always fantastic and encouraging. And thank you for the kind words said about me. I only have 30 minutes, so what I'll try and do is I'll launch into the topic straight away. I hope that we get a bit of time towards the end for discussion, because for me, that's always the interesting part. As I work as a forensic psychiatrist in the UK, I work in clinical psychiatry, and so what I'll try and do is I'll focus on as much as possible is on the practical aspects of assessing and treating people who commit sexual violence. So I'll rather not keep it as an academic presentation, but more as a practical sort of guide. So I'm just trying to share the screen now. Can you see the screen, everyone?
Yes, sir. Yes, sir. It's
Yeah,
visible, sir.
okay, fantastic. Thank you. So what I'll try and cover is to try and talk about what is sexual offending, and sometimes it may be tricky to actually decide whether there has been a sexual offense or not. And then I'll be talking about when do forensic psychiatrists come into the picture, why they're asked to assess someone, and what do we exactly assess. Then how to go about an assessment, what do you look in an assessment, and the last bit is how do we try and treat and manage. So forensic psychiatrists is the specialty which deals with the risks of sexual violence in the UK. So it would be useful to actually quickly focus on a small but significant distinction between sexual offending and sexual violence. Now, sexual offending, of course, is an act which is a crime for the particular legislature and involves sexual elements. But what constitutes a sexual offense may vary across legislature. So when I say legislature, it means that it may vary across countries, or it may also vary within a country. For example, in the US, there are some acts which are criminal in some states, whereas they are not in other states. So, for example, age of consent may vary across countries. So what's consensual sexual act in a country may be a crime in the other country. There are very different laws regarding homosexuality, whether forced sexual activity within a marriage could constitute rape. It differs in various countries. Strangely, bestiality is although illegal in most countries, but not all. And whether incest is a crime or not is again variable across legislature. So sexual offending, what is a sexual offense, can vary across legislature. But we have to bear in mind that as forensic psychiatrists, often we are called to talk about sexual violence or to assess sexual violence, which is slightly different than sexual offending. So sexual violence is actual attempted or threatened sexual contact with a person that is non-consensual. And that's a pretty much standard accepted definition of sexual violence. That's what we work to. Now, it's a very interesting scenario to consider that there are some acts which are sexual, which constitute sexual violence, which constitute sexual offending, but are they parts of sexual violence? Can we say that they're sexual violence? So some of the examples are bestiality, possessing indecent images of children, and necrophilia. So at least in the UK, all the three acts are illegal. The second one, of course, is a particularly serious crime, and it's interesting to think whether it is, can we describe it as sexual violence, simply because it doesn't really meet the sort of definition of sexual violence which I've referred to earlier. So, so there may be a bit of an overlap between sexual offending and sexual violence, but of course the picture is not as clear cut as before. So when do we come into the picture? What's the trigger point to call a forensic psychiatrist to assess someone who's committed a sexual offense? So usually, and the most common point is that someone who's been convicted of a sexual offense is to be sentenced, and the forensic psychiatrist is usually called on to give an opinion to the court regarding the disposal or sentencing. Sometimes forensic psychiatrists can also be called upon when someone who has a history of sexual violence or risk of sexual offending in the future is being released from either the hospital or the prison. And the last is that sometimes forensic psychiatrists are called in if there has been a significant or a concerning event in the community or in the hospital. So the police may or may not have been involved, but there are some concerns about the risks of sexual violence. So that's when a specialist assessment will be triggered. And one of the key things that we will be asked is to comment on what's the risk of sexual violence in the future. And when we say risk, we need to comment on not just the likelihood as to how often or when the risk might happen, but it's also about the severity. What's the severity of harm that might occur to the recipient? So, for example, if someone has committed an act of, say, voyeurism, and the risk of a similar act is likely, the severity of harm to the intended victim may be very different to say someone whose predominant risk is that of rape. And the assessment also needs to focus on identifying the factors that contribute to this sexual violence or sexual offending. And the reason for that is why we need to sort of identify these matters is that they assist the courts or the prisons in the disposal of the patient or the person at risk, or sort of at the center of the assessment. And most importantly, it allows us to recommend any treatment or interventions to manage the risk. So the assessment is not an academic exercise, but it is actually an important part to reduce the risks to the public. So in terms of the broadly, in forensic psychiatry, and generally it works in probably all branches of psychiatry where we assess risk, is how we assess risks. So there are three important sort of ways or approaches to assess risk. First is the clinical judgment. We see a patient, use our clinical expertise, and give an opinion. This is the least structured way to assess risk. It's the least accurate way to assess risk. It's not recommended that we do this, but strangely, this is the most common way of assessing risks, because every time we see someone, we are assessing some risk or the other, and it's impractical to do a structured assessment all the time. And the second is an actuarial risk assessment approach. So actuarial is a word that comes from the insurance companies, and it's called as a non-discretionary approach. So what it simply means is that each risk assessment tool will have some factors which are either present or not present, and they are identified using empirical data. They are all called as static factors in the sense that they don't change. And it's used to give a prediction of the risk. So, for example, static 99 is such an actuarial risk assessment, which is quite widely used in the UK, outside the UK. And there will be some risk factors such as, say, if someone is a male or not, someone is below 25 years or not, whether someone is married or not, and these things don't change. So they will give us a prediction. So, for example, the results could be that there is a low risk of committing of similar offences in the next 5 years. Forensic psychiatrists or psychiatrists in general tend not to use the actuarial assessments. Most of these assessments are used by probation colleagues, not psychiatric colleagues or even psychology colleagues. So what we use is a structured professional judgment. It's called as a discretionary assessment. So what we do is we use a combination of static and dynamic factors identified according to by the risk assessment tool. So I've already explained what a static factor is. A static factor is a factor that doesn't change. Say for example, someone has a history of schizophrenia. They will always have a history of schizophrenia. If someone has committed an offense of burglary in the past, that will always be there. That will never change. But when we talk about dynamic risk factors, these are the risk factors that change. So, for example, a dynamic risk factor would be insight into sexual offending. It could be an attitude. So it may be an insight into mental illness. It may be compliance with treatment. So that can change over time. So a structured professional judgment allows us to actually take into factors things that may change with treatment. So a structured professional judgment is favored over the previous one, at least by clinicians, is because it leads to a clinical formulation. It is better able to inform treatment. So this approach is often called as a guided clinical decision making. So one of the most commonly used tools to assess risk of sexual violence is the RSVP. It's called as the Risk of Sexual Violence Protocol, and that's one of the most commonly used tool in the UK and outside the UK, and that's the one I use when I assess these risks for the courts. So how to assess a risk is the answer is simple in the sense that you need to take into account as much information which is available to you as is possible. So if someone is involved in a court, then of course you will be given a copy of the witness statements, forensic evidence, criminal record, and so on. You would want to interview the person. Of course, usually in a court setting, we get a chance to interview someone only once. But if there is a need as such, you can interview someone on more than one occasion. If someone is in a hospital, then it's a different setting. You can probably interview them on more occasions. You'll try and get hold of the medical records. If other records are available, you will want to get hold of them as well. And of course, if you can speak with friends or family, it may be a bonus, but it may or not. That luxury may or may not be available, especially when you're preparing reports under a very tight deadline. So we talked about the risks. So when we are interviewing someone, we are looking for factors that are relevant in assessing the risk. So these are factors that either increase or decrease the risks of sexual violence. We talked about static or dynamic factors, so factors which will never change or factors which change over time. But to assess the risk of sexual violence, there are some factors which are specific factors which are specific to the sexual aspects of the offense, and I'll come to that. And then there are general factors. So these are general risk factors which increase the risk of sexual offending in general. For example, alcoholism. A history of impulsivity, a history of violence, non-sexual criminality. So someone with a general offending behavior may be more likely to commit a sexual offense. And the general factors effectively imply that someone's control on their actions or behaviors is actually less optimal than someone without those factors. There are many risk factors that one needs to consider and document in an assessment. But what I'll try and do is given the tight deadline for discussion, I'll try to keep things to the minimum and try to focus on some of the core issues. So these are some of the very risk factors which are specific to sexual offending. So in other words, they are only relevant when you're assessing the risk of sexual violence. So some of the things like chronicity of sexual violence is simply about how many times someone has committed a sexual violence, and the more chronic it is, more events in the past, the longer the behavioral pattern is, the more likelihood of sexual violence is. I mean, and that is stating the obvious. You really don't require a forensic psychiatrist to tell that. But what you also need to focus on is escalation. So if the frequency of events has increased recently, that's a big worry. You also need to focus on diversity. So when we say diversity, it is not necessarily in a positive sense. We're talking about the methods of sexual violence. So whether someone is also downloading indecent images, whether someone is also approaching people in the park, someone is also engaging voyeurism. So different types of sexual criminal sexual acts or sexual violence is more worrying than someone committing only one type of violence. So then the victims, the more the sort of victim range, the more risk it is. So for example, someone who has committed offenses exclusively against adult women versus someone who has committed offenses against children, male, females, pubertal, pre-pubertal, and sort of adults, that risk factor is worrying. We need to think about physical and psychological coercion. So physical coercion is pretty straightforward. It is either the threat as actual threat or actual harm used to inflict sexual violence. But the psychological coercion is also important. So it can often be called as sometimes grooming as well. So it's not necessarily a blackmail or a threat. It can also be grooming or enticement. That's also, we consider it as psychological coercion. So any coercion that is used increases the risks because it may, and especially if it is planned. Now, coming to the most important risk factor, apart from chronicity, that is the previous sort of acts, the sexual deviance assessment is actually pretty critical. So sexual deviance as a risk factor is important because if it is present, the risks of similar activity is very, very high. So what is sexual deviance? So sexual deviance is simply put is that what is a person aroused by, and is that deviant from the social norm or the legal criteria. So if, say for example, I'll give you sort of a few scenarios because this is an important risk factor, and sometimes it's difficult to establish. So say for example, someone are being attracted to a heterosexual female, you wouldn't say that there is any sexual deviance. That's the norm. That's acceptable to everyone. So that's not only meets the social norms, but also legal norms in most countries. So that kind of attraction is definitely not sexual deviance. People being attracted to the same sex. So previously, it may have been treated differently, but now that is not treated as sexual deviance, and irrespective of whether it may be a crime or not in any country. Someone attracted to children is treated as sexual deviance in most countries, most legislatures. So that's where we start establishing. So what drives someone's sexual urges, acts, or impulses? What's the predominant driving factor? And is that deviant? And then that's where the key is. So if someone is being attracted by deviant interest, then they're more likely to follow that. They're more likely to repeat that. You have to bear in mind that people who have a deviant sexual interest may also have a normal sexual interest as well. So, for example, we see many people who commit offenses against children are also attracted towards adult consenting age men or women. But if someone's sexual attraction is predominantly deviant, then that further escalates the risks. So, for example, if someone is attracted exclusively to children, then the risk is through the roof. Risk is high because that's their only sexual interest, and they're highly likely to act on them. I'm just presuming we have a few more minutes, or am I pushing the envelope?
You have 10 minutes more. 12:45. We would like you to end. So, but we could have a little 5 more minutes. But
I'm all. Yeah. Well, thank you, Dr. Netto. I'm actually almost finished, to be honest, so that we have some time for discussion. So sexual deviance is very important. The other thing we have to bear in mind is to establish sexual deviance, a single act may or may not be, is sometimes very difficult to, is not enough. Sexual deviance is really established on a pattern of behaviors over a period of time. And so that's sexual deviance. Again, some of the specific risk factors we look for in a clinical assessment is an extreme minimization or denial of sexual violence. So it was nothing. I don't do this. Why should someone complain about that? And then attitudes that support or condone sexual violence. You need to look for them. Sometimes people will not tell them. When you ask direct questions in the interview, and you may have to make indirect inferences from what they've said before, what they've done before. And again, these two things, if are present, increase the risk because they mean that the cost of sexual offending to the person, to the perpetrator, is minimal. Lack of self-awareness is again an interesting risk factor. So lack of self-awareness is not just about awareness of sexual feelings or thoughts. It's also about whether are they aware that they get angry? Are they aware that this is happening to them? Are they aware of their physiological arousal or reactions? And people who are not aware of themselves or how they are at the time are more likely to sort of commit acts. Then we also have issues arising from child abuse when they themselves were victims. And that again increases the risk of sexual violence. Then these are general risk factors which are not specifically associated with risk of sexual violence. So a psychopathic personality disorder or psychopathy, major mental illness like schizophrenia, bipolar affective disorder, the substance misuse. So these are all general risk factors which increase the risk of sexual offending by simply because those people are less likely to manage their impulses or thinking. Again, these are very general risk factors. I will not go into the detail. They are really self-explanatory. So when we finish an assessment, what should really the report contain? cannot really just tell whether the risk is likely to occur or not. I mean, to be really honest, when someone is before the court already assumes that this thing may happen again anyway. So they're not really going to waste their time asking you to tell them that. What they really want to know is a case formulation, in the sense that why this sexual violence occurred, why this act of sexual offending occurred, what actually led to it. Not only whether it is likely to occur in the future, what's the imminence? Is it likely to occur at some time in the future, or actually the risk is high, it can occur now? And if it occurs, what's the severity of the harm? The assessment needs to point out higher risk scenarios when the risk is most likely to happen. For example, someone has actually started drinking again. That's the highest point of risk. Someone is at the highest point of risk if they have financial problems. Someone's risk is through the roof if, for example, they have relationship problems. So those are the things. Then the assessment also needs to identify the victim profile. So when someone offends, who are the likely victims? Are they family members? Are they children? Are they women? Are they boys? So or are they members of the random members of the public? Because the risk management is all entirely based on that as well. Apart from the negative things, we need to identify protective factors, things that are positive as well. So what helps? So someone being in a job, does that help? Someone actually having some kind of friendships or professional relationships, does that help? So all those things need to be highlighted in the assessment. So in terms of management, I mean, again, to just sort of wind down pretty quickly, is that one of the things we need to talk about is where the patient can be best managed. What's the setting? Would you recommend someone to go to hospital? Would you recommend someone could be managed in the community? And if not, then effectively you're telling the court that it's a prison sentence. Now, as doctors, we can't recommend prison sentences. We can't tell the court whether someone should go to prison or not. We can only say, do they require hospital or not? And we spell the other things out. So then of course the key strategies are monitoring or surveillance. It basically means how will you keep an oversight? Who is going to be in touch with the person who is going to see how things are on a day-to-day basis? That's monitoring. And surveillance is basically restriction of activity. So what can you impose some restrictions? Now, for example, if someone is in a hospital, if someone is in a prison, that's surveillance, that's supervision, that's a restriction. So they can't go out on their own. And that then suddenly reduces the risk. So victim safety issue is that if specific victims are identified, you can do something to protect them. So for example, if we have people who commit offenses against children and they are in a hospital, what we will do is that we'll often not give them leave during school holidays. So they won't get leave during school holidays. So when children are out and about, we'll try and avoid giving them leave even during school days, before 9 or after 3:30 when the schools close and the kids are more likely to be there on the streets. So those are the things which we can do. So in terms of the more specific treatment, if there is a risk factor identified, we can work on that. For example, if we identify that a risk of historical sexual abuse is an important factor, we can try and work on that. We can also give specific treatments. So specific treatments can be psychological or medical or pharmacological. The sex offenders treatment program is a group therapy here, which was the mainstay of sexual offending. There was a recent article published which was somewhat critical of the SOTP, saying that it increases the risks, but as it stands, it still is an important part. And then secondly, we can use anti-libidinal medications. They can be oral or injectable. The trend is now more towards injectable. I have patients on injectable anti-libidinals because you can assure the compliance. You can be sure of that.
I'm sorry to interrupt, but you have 1 minute more.
No, thank you, Dr. Neto. Actually, I'm happy and I'm pleased to tell that I've actually finished.
Maybe we could just have a question because you were interested to have a discussion. We may not be having a big discussion. If no one is, because I'm looking at the chat box, there's no question there. So maybe I would like to ask Dr. Sibi that, Dr. Nikhil, that, in India, when we give a report to the court, it's just one page. Of course, we have the case paper with the notes, but you seem to be having done extensive documentation. So how do you do this documentation? Like, what is the quantity of papers and all? And how much is fact, fake? And how much is the confidentiality in this reporting?
Okay, so I'll quickly talk about the confidentiality. So because this is a report to the court, we have to seek very specific consent from the patient. So for example, even if someone is under my care, I can't use that to prepare a report. So the consent for the court report is very specific. I can actually share the consent form that I actually use. But briefly, what it needs to cover is that they need to know that the report is for the court. It won't remain confidential between me and the patient. It will go to the court, and of course will be read by the judge and the prosecution. And they need to consent. Now, very occasionally they don't consent. So in that case, what we need to do is to then go back to the court and say, what do you want me to do? Do you want me to still go ahead or not? So broadly, if someone doesn't consent, then you can't prepare the report unless the court orders you to do so. So that's where the consent is important. But what generally happens is that the defendant is made aware that if they don't consent, then the court is going to draw adverse inference from it. So most of the time they consent. Sometimes they don't when they're very unwell. So that's consent. So in terms of the documentation, how much we review, it really depends on the case. So when you are preparing a report for the court, as an expert, you are really entitled to see all the court papers that are being used by the judge, being relied by the prosecution or the defense. It's a very odd occasion where the judge will say only release so much and so much. But that's often to your advantage, because then it means that you're not actually reading reams and reams of technical data. But ordinarily, whatever everyone sees in the case is what you get to see as well. And then there are the medical records. So you can ask the defense team or the prosecution team to get hold of their medical records. And then they can be like 50 pages, or they can be 1,200 pages. Especially if they're admitted to a hospital or something like that, then the records can be quite extensive. So in terms of the report length, my report is generally around 30-35 pages. I do use a set template and a format so that I structure my arguments, but the court per se doesn't require it to be a particular format. So it's for me to make sure that I've covered every issue. So that's where I don't know whether I've answered some of the questions.
Yes. Thank you, Dr. Nikhil, very much. It was a very enlightening talk. So we will have to end as there's another speaker waiting to take over. Thank you very much. Thank you very much.
Thank you.
So maybe we could have the biodata getting ready for the next speaker. The next speaker has been given to us is Dr. Saibal Guha. Dr. Sabi, would you like to please introduce him, the next speaker?
Yes. It's a privilege for me to introduce our next international speaker, Dr. Saibal Guha, who is a senior colleague from military psychiatry. Dr. Guha did his post-graduation in psychiatry from Armed Forces Medical College, Pune, and served in Indian Navy as a consultant psychiatrist. He later emigrated to Australia in 2004, and he completed his fellowship in Royal Australian New Zealand College of Psychiatrists, and worked extensively in public mental health services in South Australia and Queensland in various clinical and administrative positions. Currently, he is in private practice at Brisbane, Australia since 2011. His areas of expertise is in adult psychiatry with a special interest in adult ADHD, neurodevelopmental disorders, and neuropsychiatry. He will be talking to us on ADHD. Dr. Guha, please. Sir, your audio to be switched on.
So we are unable to hear you. You will
No, you
require
have
to
put on your
join the
audio.
call. Sir, you will be required to join the call for us to be able to hear you. So we can't hear you.
No.
Yes, now we can see you, Dr. Sibal. We can't hear you. We can't hear you, but we can see you.
Maybe you can try log out and log in again, sir.
Dr. Supriya, do we have the next speaker ready?
No, sir. Unfortunately, we do not have the next speaker ready with us. He is Dr. Renuka Prasad, and he is scheduled to arrive by around 1:15, sir. Really sorry for this, sir.
Because his audio may take some time to get sorted out.
Yes, sir. I understand, sir. So we're just trying to help him, sir. Sir, your audio is still on mute right now. Okay, so Dr. Renuka Prasad is here with us right now.
Hello, can you hear me?
Maybe we could have
But
Dr. Renuka Prasad introduction, and then you could go first, and then Dr.
But I think we can
Sibal
hear
could take
Dr. Saibal right now.
Okay.
Yes.
Come back.
Yes, sir. Dr. Saibal, we are not being able to hear you right now, sir. So, according to Dr. Neto, sir, may we have Dr. Renuka Prasad present before you, if that is okay, sir. Till then, you can just kindly please adjust your audio.
If you can put up Dr. Renuka Prasad's biodata.
Yes, sir. We're just doing that, sir.
Hello.
Yes.
To load the
No, 1 minute,
slides.
Dr. Renuka Prasad. We will be just reading your biodata and introducing you. Just a minute. So we have Dr. Renuka Prasad, who is the third speaker. But because of the audio problem, we may take him before. So Dr. Renuka Prasad is a clinical professor. Now his university has a tongue twister, Saskatchewan University, Canada. I hope I've pronounced it correct. Dr. Renuka Prasad has also done a lot of work on ECT and RTMS, and he is a well-known geriatric psychiatrist in Canada in this Saskatchewan University. He has done many clinical trials. He's also a fellow of the Canadian Psychiatric Association, the American Psychiatric Association, and a fellow of the Royal College of Psychiatrists, United Kingdom. He has been the president of the Canadian Psychiatric Society, the various prestigious posts in the year 2016 to 70. He is Zone I representative of the World Psychiatric Association Triennium from the year 2020 to 23. So it's nice to have again another senior geriatric psychiatrist from Canada who has his roots in India. So over to you, Dr. Prasad. We're really eager to listen to you.
Are you able to, I have a problem in terms of sharing my slides. Are you able to do that?
Yes, sure. Someone can do it for you. Dr. Supriya, could you present the slides of Dr. Prasad while he speaks?
Yes, sir. We're just looking into it.
Yes, yes. And at the same time, you could get Dr. Sibal's audio and all.
Yes, sir. We're
sorted
speaking
out.
to him. We're communicating with him right now, sir.
Are you able to access my slides and my screen?
Yeah, they are trying to get your slides projected.
Dr. Prasad,
Yeah. Right.
sir, have you mailed us your PPT? We were under the impression that you will be sharing it yourself. So we don't have it in our slideshare, sir.
Oh,
So in case,
isn't that nice? I mean, oh gosh, I can mail it to you.
yes, sir. Please do that, sir, right now. So we'll immediately display it, sir.
Send a copy to.
So ANCAIPI 20.
So that again, ANCA.
IPI.
Yes, 2021.
Yes, sir. @gmail.com.
Yes, and subject is there the slides, I'd say, and then I'm going to send it right now as we are speaking.
Yes, sir. Thank you so much, sir.
Usually I was able to Can you sleep? You can't sleep my slides, is it?
No, sir. We're not being able to see your slides right now. So we'll just download it and start sharing in a bit, sir.
I would request the audience, there is a chat box where you can put your questions for the speaker. So up till now, we have not received many questions, so please do.
Are you able to get my slides?
So we're just looking into it, sir. So we're just downloading it, sir. Yes, sir. We're starting, sir.
Dr. Renuka, your slides are visible to us. So you can begin presenting from your side.
Okay. So how would I move the slides?
So you just have to say next slide, please, and we will shift it for you.
Holy man, that will be an interesting one to start with. Okay.
Okay, sir. Or we will keep it tab and we will just keep shifting it, sir.
Thank you. Thank you very much for inviting for me to talk, about the impact of COVID-19 on seniors' mental health. And next slide. is technically to review the COVID-19 status in India or in Canada, as we know, coming from India, and see how it goes, and then impact of its seniors and what lessons we learned so far. Next slide. As you all know that in COVID-19 was the first, of course, was described in Wuhan region in China in December of 2019, and the WHO declared the pandemic in March, almost 1 year ago now, March of 2020. And before we talk about it, I just wanted to share some current demographic data. And as you can see, as of 2nd of March 2021, we have almost about 2.5 million people died of COVID, and over 114 million people worldwide have a confirmed cases of COVID. The same diagram, I'm going to share it in a bubbles, and that tells you how kind of how the COVID has affected all across the globe, and of course, some part of the world seems to be affected more than the rest. And the similar pattern as well when you're looking at the confirmed case of who have been passed away, that there are 2.5 million, as you can see, across the world globe, and the way it has panned out in the bubble 2 in the globe as well. We'll go to the next slide, slide number 9. That is just coming to Canada. For those of you who do not know much about Canada, Canada is the second largest country by total area. It has about 37.59 million people, which has been grouped in 10 provinces and 3 territories. Bear in mind, healthcare in Canada is delivered through provincial and territorial governments, not by the federal government. So another important features to bear that in mind as well is Canada is a publicly funded universal healthcare system, and it covers complete medical care, hospital care, most of medication cost, basic cost of the long-term care, limited home care for people over the age of 65, no direct financial barriers to access to healthcare in Canada. With all this meant was that Canadians were generally spared from massive disruption, as most people have seen, particularly from reports from the States or from Italy. The next slide. Canada, unfortunately, has an aging population. We account for about 16.9% of the total population is over the age of 65. Of course, we are not as bad as Japan, but we are pretty in the bottom of the G7. Next slide. I just wanted to run it by you some of the demographic data which might try to explain some of the things what I'm going to tell you later. As I mentioned to you, the healthcare system in Canada is delivered by the provincial care. And as you can see on February 25th of 2021, the total number of cases all across the country was about 858,217 cases. As you can see, there are some provinces which have a darker blue color, which has got more affected more, particularly the Quebec and Ontario, whereas the rest of the other provinces were not as badly affected as they were. And if you go to the next slide, which tells not only the cases we have, but also the number of cases recovered from all these jurisdictions too. So if you compare to 58,000 cases, we are more than 806,000 recovered from the COVID. And we do have our share of deaths, needless to say. And once again, it does vary from province to province. So as of 25th of 2021, Canada has about 21,865 people have been reported dead from COVID. And of course, one of the biggest impact is on the hospitalizations, as you all know. And if you look at that, in Canada, the number of, or the percentage of people who got hospitalized, as you can make out, the people who are over the age of 60 and above are accounted almost more than 50% of the total number of hospitalization. Not only that, but it also meant even the people, if you're looking at the people who are deceased, the percentage of people was also pretty higher. For example, as you can see, the people who are over the age of 80 plus and above were 69% of the, accounted for the 69% of the death of the total deaths. And if you add up all the 60 and above, technically, we're talking about 90% of the people who passed away. Right now, as we are facing, we're coming through the second wave. As you can see in the 25th of February, and I'm preparing the slide, we can see we're coming down in the second wave. And in the last 7 days across Canada, there were about 3,000 new cases, and the 7-day average was about 2,961. So this is just to give in my province, it's Saskatchewan, that's the word. So it's a tongue twister, of course, I acknowledge that. And we have a population of 1 million, and we have about 380 deaths so far. That is compared to 21,904 deaths across the country, and across the world, of course, we got more than 2.5 million. So we'll go to the next slide, which indicates that in the last month or so, our active cases are decreasing. Our hospitalization patients are also decreasing, and our recovered cases are also improving too. That is all good news. What COVID-19 does to all of us, it actually challenges the resilience, be of the individuals or of the communities, or if you put together the whole nation as a whole. That's what it really tests the challenges. Any kind of a crisis, particularly a pandemic, that's what it does. And next slide. Resilience, as you all know, is the process of adapting well in the face of adversity. It is not coping, it is more than coping. It is about coping is a behavior to protect oneself from psychological harms from bad experience, whereas in resilience, it is the process of adaptation. Next slide. So all the measures, public health measures, whether it be quarantine, travel restrictions, social activities, wearing masks, you name it, they unfortunately disproportionately affects seniors and their mental health, no matter how you cut the cake. Next slide. Also, seniors have multiple vulnerabilities as well in terms of physical, psychological, social, and environmental barriers, which adds up. Next slide. Seniors are also vulnerable for multiple infections, death, and also age-related decline in immune functions plays a part too, and their pre-existing both physical and mental health conditions too. Next slide. And there are certain changes in terms of COVID-19, which kind of provided some unique challenges to all the society, including Canadian society, in which the ease of transmission of affecting even so-called healthy people, which affected of course, all the society, and of course, the delivery of mental health care, and also the mental health of all Canadians, including seniors. Next slide. Canada was actually, in a way, had a bitter experience of 2003, an experience of severe airway, called as SARS, airway restriction syndrome. It is similar to kind of a viral breakdown we experienced in 2003. During that SARS-1, there was a lot of disasters which caused an uproar both in the provincial level and at the federal level. So what happened at that time in Canada was, there was, of course, after a lot of bickering among all the different agencies, there was an increased funding. There was a lot of money spent on the public health system, and also the integration of both the federal and on the provincial governments in terms of communication, in terms of how to be messaging to the whole nation as a whole. All this, in a way, prepared in mandating and implementing the social distancing, closure of the non-essential services, including businesses, schools, recreational facilities, places of worship, and individuals to be able to stay at home except for a brief period of purchase for essential goods and for exercise. All this had a successful impact in limiting the burden of COVID-19 on the hospital system. Next slide. However, these public health measures which improved had a significant positive effect on the hospital care system, unfortunately also had some negative effect on the seniors too, particularly delivery of the mental health care. And of course, there was variations among the various provinces how this is affected as well. Next slide. Among the psychiatrists, of course, one of the most aggressive treatment, if you want to call it, is the ECT, and that was actually abandoned during this process. It was many authorities believed that it was a non-essential services, whereas psychiatrists argued it as essential. Obviously, even though the changes were proposed, and it was entangled with hospital bureaucracy as well. Seniors programs, community programs, home care, they were all affected by the social distancing. Decreased frequent visit from the family practitioners also meant that difficulties in detection of many of the mental health issues, and some of them were getting even untreated. And we all know isolation, loneliness, they were all risk factors for both depressions and delirium and cognitive impairment. Next slide. All this has had a much more significant impact in the long-term care facilities in Canada. In Canada, long-term care facilities is not the part of the Medicare system. It is privately owned. It is run by the provincial jurisdictions. There are multiple regulations have been imposed, and in hundreds of institutions reported outbreak, challenges to deliver the mental health care, including staffing, they all came out in public. So much so, it was the news media and headlines came out with all these pictures, as you can see in the next slide. Quebec long-term crisis was started. Next slide. As 43 deaths and their lives, it was published in Scarborough, Ontario. Next slide. Articles and presentations were paid, and we need ethical and ethical compass for fixing the problems in long-term care. Went an article. This is the premier of one of the big provinces in Canada, Ontario. He admitted publicly there is a staffing crisis. Next slide. There are protests and marches within the society. We can see patients not for profit, no more cuts. This was happened all throughout the fall of 2020. And the next slide, how many reports will it make it fix the long-term care? Next slide. Solutions. Of course, our Prime Minister kept on coming onto the media saying that nothing is off the table, and he wanted to do many, many things to the Canadians as a whole. And what it really meant was to how do we enhance our resilience, both at different levels, at individual levels. How do we improve our social distancing, social isolation, which is actually an important component in enhancing one's resilience. And that was compromised with social distancing measure implemented by the public health. And the use of adapting of digital technology, volunteers befriending, enriching spare time activities, they all found newfound meaning in the post-COVID era. Next slide. Solutions were thrown out in financial incentives and protections for the most affected. In fact, many people who lost their job, their salaries were all kept not at base level all throughout for this year. For the medical profession and other professions as well, fee schedules and everything were also being streamlined. So virtual care was literally transitioned into overnight because we had an established telemedicine infrastructure before, which was not used. Seniors Day program, supports program, Alzheimer's addiction services. By the end of April of 2020, they have all gone virtual. Next slide. So community-wise, also we needed to improve the resilience. That is to withstand, adapt, recover from the adversaries. And particularly the hospital infection protocol was implemented by the end of March of 2020. Everywhere, PPE, sanitization, social distancing, everything was limited in terms of the infection protocol. Then many of the operative procedures were cancelled, mainly to minimize the airborne AGMP procedures. ECT, of course, has been our ECT rooms were all changed in the use of negative pressure rooms by the end of April to May. But when it comes to the long-term care though, that was a different story. What it did was it exposed many shortcomings of the systems. underfunding, understaffing, overarching regulations. Nonetheless, many staffs were able to use innovative ways, use of tablets, iPads, they were all used to support each other. In spite of it, some challenges do remain. Next slide. Resilience in the community. In fact, all our local temples and mosques and gurudwaras, they have not had opened, but they are all doing virtually since the end of April of 2020. All of the volunteer organizations have gone virtual too. What I believe is that having this presence of infrastructure, volunteer service, which is very well known in Canada, helped to take the burden of the COVID significantly. Next slide. Of course, as a nation, we need all to face a crisis like a COVID. It also has to have a resilience too. That means to say it needs to absorb, respond, recover from the disaster, and to adapt to a new situation. The ability of all communities to work together to support from at all levels, be that be government, be that be private, is a useful thing. And our SARS 2003 helped us a lot. We are not perfect, but we are getting there. These are all our seniors, our leaders. The Prime Minister saying, of course, how wonderful we have been doing. Although opposition saying,
Dr. Renuka, I'm sorry to interrupt you, but you have just 5 minutes more.
That's
so
okay.
If you could just
coming to
Thank you.
Okay. And all the opposition's leaders saying that how shortcomings the system has been, and the shortfalls of the whole take care. Of course, that is the part of the democracy. The party which is governing says how wonderful they have been doing. Future, what it holds is that as we are emerging from the second wave, it all depends upon how we contain our spread, the disease, and how fast the population get vaccinated. And we believe the sustained integration of the virtual care in mental health, much more so in the senior mental health, will be going to be the case in the future. There will be a big talk about Canada in COVID-19 is the long-term care reform, which has been started, which has been chronically under-resourced, and which needs a lot, all the staff needs training and job security. Next slide. As we evolve, problems dissolve, but we evolve. Thank you very much. And this is my references and questions time.
Thank you, Dr. Renuka. Thank you for, hurrying up your talk, but we are very sorry. It was very interesting. Since there's no question here in the chat box, but maybe you can answer this one question briefly before we go to the next speaker. Is, you are specialized, especially in geriatric care. In how did you all manage your ECTs? Because in the West, mainly the geriatric population get a lot of ECTs, whereas here in India, the young people get the ECTs and not so much the geriatric.
True. For the first few months, particularly in the month of when the lockdown happened in March, the whole ECT suites were shut down until the end of April, almost you can say for 6 to 8 weeks. In that interim period, we have implemented the negative pressure rooms. And, I remember going to the ECT suite with a suit and jacket and administering the ECT. Nowadays, I go and administer the ECT with gowns and gloves as if I'm doing it in a surgery now. That is the kind of infection protocol we are following. And also, anybody who is coming from outpatients, they all have a COVID test done too. It does affect it, but it took a beating, but you were able to recuperate the ECT administration.
Thank you. Thank you very much, Dr. Renuka. Thank you very much for your interesting presentation. Nice to hear about all the things going on in Canada. Very
Thank you.
important for us Indian psychiatrists. Thank you very much. Now, maybe we could connect Dr. Saibal Guha, please.
Sir, can you hear me now?
Yes, sir. We can hear you. Yeah, we are
Thank you
waiting
so
for
much.
you to start. Yes.
Okay, I'm going to share my slides. Just give me a moment to share the screen. Yep, share. Look, I think I've lost a bit of time trying to connect up and doing all the electronic stuff that is very difficult. And I definitely know a lot of faces with my seniors, my teachers who are there. So without wasting time, I will jump into my presentation. This is about management of adult ADHD in clinical practice and my experience from where I practice here. I'm associated with a 150-bedded private mental health facility and run our own private clinic called Marsai Clinic in this facility. And they do have admitting rights. So how did I reach this adult ADHD forum? Because during my training in FMC and subsequent working in India in the Navy, I don't think we had much of a discussion or any teaching per se about adult ADHD. ADHD, from when we were taught, only happened in children and possibly adolescents, but never adults were talked about in the ADHD forum. So while trying to work in Australia from 2004, certain cases started coming up and my interest started growing because my supervisors and mentors talked about adult ADHD in some kind of relevant terms to people's journey and getting better and the transitioning from childhood to adolescent to adult. Though it was a bit of a tricky area for me, but I soon started getting the idea that adult ADHD is quite a prevalent disorder. It is quite prevalent in India, in China, in Western world, and also in Eastern world. Maybe we don't look at it quite closely. So the prevalence rates in adulthood are about 1.1 to 2.7%, and there is a persistence across gender about 55.3% for full criteria, and a very variety of statistical issues around the 40 to 50% persistence. The symptoms are generally associated with a lot of conflict with parents, poor health, sexual assault during childhood and later on, educational aspects, loss of income, and obviously a very high rate of unemployment, which generally gets adults to be referred to adult psychiatrists for ADHD assessments. The prevalence of conduct disorders and problems for adults with ADHD is quite high, and you can say it's 57%. And definitely people, children who had conduct disorders, conduct problems, have more disadvantages as an adult and if they continue to have ADHD. So the burden of illness is quite significant, and as you can see, it's a 90% heritability rate for this condition. So it's a significantly heritable condition. And 80% of adults have at least one comorbidity, which could be anxiety, depression, bipolar disorder, substance abuse, any of these, and many others. So recognition and treatment of ADHD is in adults, and along with its comorbidities, actually has led to a lot of positive benefits and results. You can see that from the big pool of children with ADHD diagnosed and treated, when they go to adults, 50% retain the full DSM diagnosis by age 25 and beyond. 50% of them actually are partial remissions, but about 2/3 of the children have persistent level of impairment for ADHD as adults. So it's a significant problem. If we don't scope, we don't know. So I know time is of essence, and I've missed out time due to my technical problems. So I'm not going to go into each slide in detail. So I might rush through the slides, but happy for me to field questions later on. The main presentations in adults, not so different from children, are not in a particular order. Disorganization and forgetfulness, they procrastinate. There's significant time management problems leading to job losses or issues in universities. They can prematurely shift up activities because they're distracted by something else. They're very impulsive. There are a lot of criminal offenses, unstable jobs and relationships due to emotional sensitivity. There is a symptom called RSD, rejection sensitivity dysphoria, that we talk about in ADHD, and that causes a lot of relationship difficulties. They all have low self-esteem and definitely self-confidence. If you just quickly look at the comorbidities of ADHD, for which often patients get referred by general practitioners in Australia, they are in the realms of not treated major depression, which is not responding to antidepressants or anxiety for that matter, bipolar disorders, mood swings, but does not fulfill bipolar 1 or bipolar 2, with a lot of emotional instability and rejection sensitivity. Substance use disorder, about 40 to 60% of people with SUD have underlying ADD or ADHD or even ASD sometimes. So these things actually impair social, occupational, and recreational functioning, and becomes a point of concern for the general practitioners, families, and also the individuals. So they come to us, they get referred to us. The common risks associated with ADHD are a variety of mood instability, anxiety, depression, dissocial behaviors, substance use, obviously, and low self-esteem. These actually shakes the person's ethos and their understanding of themselves. So the self-development gets quite skewed. They have driving accidents, they have academic failures, they have multiple course changes and loss of money as a result, because you pay fees and you can't get the fees back from the university. The unemployment rate is significantly high. They have marital discord, relationship breakdowns, even domestic violence. They have inconsistent parenting and also maltreatment of people under their care. So that there is a significant amount of social disturbances as well as cognitive disturbances noted in this adult population who are untreated or undiagnosed. Common manifestations which does not fulfill DSM-5 present criteria, which I'm sure DSM-6 might consider down the track, are procrastination, time management problems, difficulties in starting a task or changing to another task or multitasking. Adaptive behaviors, they don't adapt, they're very concrete, they're very inflexible in their behaviors, and they feel that they are not doing well, and the manifestations sometimes don't happen, especially in girls, because women with adult ADHD often don't manifest with behavioral disturbances. They are a completely different kettle of fish. But that felt issues can be objectively or subjectively quantified and checked. They are quick to make decisions. They're very impulsive. They have low frustration tolerance. And obviously, there are issues with mental fatigue and tiredness. What exactly is implicated in ADHD? If you see the brain cognitive sphere, it is the inhibition and planning, which is the prefrontal cortex issue. Attention could be prefrontal basal ganglia issue. Organization, problem solving, motor control, they are more cerebellum, anterior cingulate gyrus, and locus coeruleus issues. So the three implicated neurotransmitters are noradrenaline, serotonin, dopamine. More the epinephrine group and the dopamine group is more implicated with adult ADHD. I think the serotonin possibly is in and out in that area. Neurobiology is very complex. Of course, if you see the executive function network, which is in black here, it goes from frontal cortex to the supplementary motor cortex, and from there, it generally comes to basal ganglia. And there is a bit of a loop between nucleus accumbens and the frontal cortex. So this loop is called the executive loop, and that creates a lot of dysfunction in the neurocognitive aspects, causing some of the behavioral manifestations I mentioned before. Clinical assessment is very complex, and this is where a lot of psychiatrists do not want to get into the field of adult ADHD, because the subjectivity of these assessments overrides the objectivity from the patient and family members. But if you try to get them in, then you get a more comprehensive diagnosis. So we need to check for lifetime history of ADHD, including childhood onset, the current experience of the adolescent or adult presenting before you, and their ramification as a child. Impairments in at least two domains, which could be school, home, or social life. Clinical record, which if you can get some clinical record from previous psychological testing and other stuff. Full medical history and somatic treatments, what has been done so far. where could be the diagnosis missed, how the comorbidity has been managed or mismanaged. They all are pointers toward whether that background ADHD exists or not. Family history of psychiatric and neurological problems often as a pointer or indicator of this issue. Mental status obviously is very important. That's bread and butter of psychiatry. So we do that when we ask cognitive questions, maintaining the DSM-5 criteria. For adults, family history may include ADHD in their own children. These people get a lot of referral. Oh, my son got diagnosed with ADHD. The child psychiatrist or pediatrician said, you need to get checked up. They often get referred and they self-refer themselves and come to us. Functional impairment should be confirmed by informants who know patient well. So I always take an history from either the parents or their spouse or their friends. So there is a bit of a history taking that really is important. What useful rating skills can be used for adults? There's a list of rating skills that can be used. I use the first two, the adult ADHD self-rating report scale from WHO and the Kronos adult ADHD. But there are the DIVA version 2.0. I work with the ADHD coach. He often does that. I don't have a license for it, but that is also a very good tool. This is a sample of the ASRS or adult ADHD self-report scale, and it is very easily available. It is downloadable from internet, and people can easily use that as a screening tool for their outpatients or inpatients. Now, treatment for adult ADHD is no different to treatment for children. Only thing is, obviously, adults has other issues, comorbid issues and substance use, and so we need to possibly maintain them here. The ADHD drugs, especially the stimulant medications, are under Schedule 8. So they are prescribed with a lot of restrictions and monitoring. And I generally use mostly the Ritalin or methylphenidate and dexamphetamine classes, which has got short-acting and long-acting variations. But that is a non-stimulant atomoxetine, which is used. People who, if anyone is interested, I can share the slides, and it's no point in going through each of them. All these medicines listed here are available in Australia. I'm not so sure about India. I think there could be some restrictions there. In my clinical practice, I do use rating scales. I do use diagnostic formulations. I also get second opinions from other colleagues if I'm a bit confused. And the comorbidities confuses you sometimes. And we as psychiatrists, when objectivity is relevantly not there, subjectivity is what we have to use. But the experience in this field always makes you a bit more wise and develop your sixth sense around what you are observing versus what information is coming across. Because a lot of people are motivated to get a diagnosis to get into stimulants. So there is a lot of biasness around getting things or secondary gains around getting medications. Investigation and thorough investigation is important because false positive results are very rampant in this area. So a lot of people get diagnostically challenged, and then you make a false positive diagnosis, and then that leads to a lot of stimulant related side effects. Medications are usually trialed for 3 months with regular feedbacks and monitoring. The current problem in our setting in Australia is the lack of pathway to care for adult ADHD. That means there are less psychiatrists doing this kind of work, and there are multiple people who are trying to get to a person like me, and most of the people have their books closed. Public psychiatry do not deal with ADHD, adult ADHD, because of stimulant prescription and everything. So it's the private psychiatry that takes on. I'm not so sure about India, but other countries I've heard similar problem is happening. We actually have a very robust private psychiatry set up, so we actually geared up to still provide this service. My other little question for us, for the audience, and people who are interested in neuropsychiatry and ADHD would be, is it a spectrum disorder? I believe ADHD is a spectrum disorder, and I'm advocating for it. We have a group of people who are working in this field asking these questions. Is it part of an executive functioning system? And as you can see from this slide, depression, anxiety, bipolar disorder, all the little blue little hyperlinks, they basically are symptoms of ADHD, but they are placed in everywhere in these diagnoses that we have. So basically, ADHD symptoms can be found in depression, can be found in anxiety, can be found in bipolar, can be found in a variety of other illnesses like impulse control disorders, can be found even in autistic spectrum disorder and learning disorders. So in itself, I believe ADHD can be part of an executive function. As you can see, ASD and ADHD share a lot of symptoms in common, and the most common ones are flexibility, planning, and response inhibition. So if you think as executive functioning of the frontal lobe, prefrontal cortex as the key center of this disorder, then a lot of illnesses which has got executive functioning problems can actually be part of this whole spectrum. So the invisible disability here is executive functioning. And we can label it as ADHD or ASD or schizophrenia related issues or head injury related issues, or we can use learning disability as a problem. They may not have all the executive functioning problems, but attention, processing speed, planning, and comprehension, these all can, in bits and pieces, can be a problem. So my summary about what I tried to present today is obviously a background history of where I started my journey, how I stumbled into adult ADHD field and has become my core practice. That there are difficulties across everywhere in the world to find an adult ADHD psychiatry. And in Australia, it's a very long waiting period. So I do a lot of telehealth across states. So it's not exactly in Brisbane that I treat my patients. This is across Australia. I have to reach out because people are really hankering for a diagnosis and treatment. The variable pathways to reach a practice, which are mostly patient related. I've done a study in 2018 and talked about this in our college congress about the pathway to care and patient feedback, did sample studies here. Web search is an effective tool. That's how people get to us, but then again, find our pathways blocked because of the waiting period. Treatment aspects and follow-up schedule. This sort of work to be done because a lot of psychiatrists here follow different treatment schedules. Their monitoring services are different. Some use high doses, some use low doses. There is no constancy. We have a ADHD psychiatry pool of people, a peer review group that actually supports each other.
Dr. Dua, you just have 1 minute more.
Yeah,
you
no
have
problems.
a minute more.
No problems at all, sir. Screening issues important. There are training of front-end staff. Nurse practitioners are being talked about to be coming into this field. And also the question about spectrum disorder. I remain absolutely indebted to my alma mater, the FMC and Indian Navy for bringing the knowledge and grounding that I had to come and be here today. And thank you for allowing me to come and present. I'm again apologize for the delay in starting. Thank you, sir.
Thank you, Dr. Dua. Very beautiful presentation on adult ADHD. There are no questions in the chat box, but I did a symposia with my students on adult ADHD, and we had a lot of problems trying to sort it out. In the diagnostic criteria, one of the diagnostic criteria which I found most useful was life history or past history in the childhood of ADHD. Have you seen any adult ADHD without a family history, a past history in childhood of ADHD? Can it just suddenly shoot up like that later on in life?
Professor Russell Berkeley of USA actually has presented on this and actually has presented papers on this, saying that yes, adult ADHD can format even and manifest even at adult life. There could be some telltale signs, but sometimes people's high intellect and the structure around them will never allow them to come out with an ADHD-like features in the child. Mainly problem is when the hyperactivity component is not there in childhood. They always fly under the radar. And if you do school reports and if you talk to parents, they say, no, my child was perfect. And sometimes you don't get the history. But there should be. It's a neurodevelopmental condition. You can't actually have complete manifestation in adulthood without any roots in your childhood. But you're right, sir. It sometimes doesn't come out even in the screening. Even testing has been done. I've got patients who has seen psychologists and could not get a diagnosis at that time, but they have prominent ADHD symptoms now. So to answer that question, yes, there is a strong possibility. Some people, due to current pressures, current job situations or their life stressors, manifest with frank ADHD symptoms that were quite masked during their childhood.
Thank you, sir. May I ask Dr. Sabi to say some few words before we close? Chairperson Dr. Sabi. Yeah.
Yes, before that, can I ask one question, Dr. Guhas?
Yes.
Sir, how common or rare is stimulant addiction dependence in your patients of adult ADHD?
it is a very big problem. Stimulant addiction is a big problem, and drug diversion is a big problem. So it's placed on a Schedule 8 category with opioids. So every prescription is monitored. I have to really literally count tablets that I have to give, and any repeat scripts, any lost scripts actually go to a police complaint before I can issue another script. So it is a problem. My patients, I screen my patients quite actively, and I don't take people with comorbid substance use and other things because I burnt my fingers a number of times in that area. So to answer your questions, I have about 3 or 4% population of my number of people, and I manage about 450 ADHD clients right now in my books, and I don't have that problem because of the proper screening and the assertive monitoring that goes on.
Thank you, sir. Thank you, sir. So we have 3 international speakers who gave perspectives from different corners of the world to us today. Dr. Nikhil Kishti talked about forensic psychiatry, and he was from UK. He talked about sexual offending and how a forensic psychiatrist deals with it, followed by Dr. Renuka Prasad, who's a geriatric psychiatrist. He spoke from Canada, give us the situation of COVID-19 and the geriatric psychiatry issues at Canada. And finally, we have Dr. Saibal Guha, who talked to us from Brisbane, Australia on adult ADHD. So thank you so much, all the 3 speakers. It was such a pleasure and a privilege to listen to all of you, especially at this time of COVID-19 and listening to perspectives from different corners of the world. Thank you so much. It was a pleasure.
So thank you, everyone, and thank you from us chairpersons for this wonderful session. Hand over to Dr. Saldana sir, Dr. Chowdhury sir.
So, we're extremely apologetic, sir, for all the unfortunate hindrances encountered in this session. And at the same time, we're extremely grateful to our respected chairpersons for bearing with us and for conducting the session so smoothly despite everything. We extend heartfelt thanks to our very eminent speakers who have enlightened us so well about the COVID-19 scenarios in countries outside India and about the extremely relevant topics of sexual offenders and adult ADHD. Thus enriched, we shall now disperse for a brief recess to gather together once again at 2:15 p.m. So would you like to say?
2:15 or 2 o'clock? 2:15. नहीं यार वो UK को बोलना है
Okay. So this session is closed then. Thank you.
Thank you, sir.
Thank you, everyone. Thank you.
Yes, sir. Thank you so much, sir.